So welcome to our Living Beyond Breast Cancer conference session on sex and intimacy. We got to talk about it. So my name is Jamil Rivers. I am a board member and young advocate with Living Beyond Breast Cancer. And I am also living with metastatic breast cancer, and I've been living with it for about 1.5 years now. And this topic is very near and dear to my heart, where I definitely wanted to participate because I am married. And I, of course, with breast cancer treatments, have had a shock to my system where with these hormonal treatments, it has definitely impacted my libido. And I've had to come up with different ways and solutions in order to still retain that connection with my husband. And so this should be a lot for us to discuss today. But I want to go ahead and introduce our expert that is presenting on this today. Dr. Monique Gary is a board-certified, fellowship-trained breast surgical oncologist and medical director of the Grandview Health Penn Center Network Cancer Program in Sellersville, Pennsylvania. In addition, she has also served as the director of the breast program since its accreditation in 2015. She is the founder of the Cancer Genetic Risk and Prevention Program at GVH, which provides genetic counseling and high-risk management for patients with strong family history of malignancy and those with known hereditary cancer syndromes. So welcome, everyone. Dr. Gary.
Well, good afternoon. Good afternoon. Can everyone hear me? So I'd like to thank you so much for inviting me here today. I do bring you greetings from Grandview Health in Sellersville, Pennsylvania, which I sometimes will affectionately tease folks and say, it's not too far outside of Philadelphia. If you go northwest about 45 minutes or so, and then you hit the little house on the prairie, and you make a right, and then you hit the big red barn and you make a left, but if you get to the wishing well, you've probably gone too far. But no, truly, it's 45 minutes outside of Philadelphia, right up Route 309. And I have some lovely friends of mine here today. I want to thank Sue Rush for coming from Grandview. She is my nurse navigator. And I want to thank Judy Ott, who's a board member of the hospital, for being here, and also a breast cancer survivor. And she's been an incredible advocate. So let's see. I got a clicker. There we go. Full disclosure. There'll be a lot of those today. Just get used to it. Full disclosure, I am not an expert on sex. Are there any sex experts in the room today? Is Ann Katz here? She's probably the only sex expert that I know. But let me tell you how I got to be here, to be the sexpert of the afternoon. I had a call with Amy and Amy and Sharon from Living Beyond Breast Cancer. And they said, tell us about your program. Tell us, what great things are happening in Sellersville and Grandview. And I said, we have a wonderful community full of vibrant women, and we have a thriving support group run by my nurse navigator, Suzanne, and my social workers, Amy and Kim. And we have great conversations like sex and intimacy after breast cancer. And, funny story, I went to the Walmart in Hilltown, which is on the way to the hospital, which is in a very religious Mennonite community. And I said, I've got to give this talk on breast cancer. So I go to the Walmart, and I go to the lube section. And I go up and down the aisles, and I must have cleared every single box off the shelves. And this is a very religious community. The Walmart is not well stocked with lube. It's like half an aisle. And I walk down the aisle, and I'm just putting it all in the cart. And I pull up to the register, and a woman is there, a little short lady, and she just looks at me like this. And I look back at her and I go, I hang my head in shame. I don't tell her what it's for. And I get to our support group that afternoon, and I dump everything out on the table, all of our spoils, and I say, okay, ladies, here it is. Here is our chance to try before you buy. I want everybody to grab a box. Come on, everybody, grab a box. This is your chance to touch it, taste it, feel it, smell it, figure out, does it make you itch? Does it burn? Is it warm? Here it is. And they all sat there. And finally, the two women at the end of the table, one was 80, one was about 78 or so. The 80-year-old said, well, I'll take one. And her 78-year-old friend said, well, I guess I'll take this one. And they open it up, and she says, strawberry, smell it. And finally, all the women, 50, 40, 30s, 20s, all grab a box. And they're all opening the boxes, they're talking about it, they're feeling it. And this was the way that we began to have our discussion about sex and intimacy during and after a breast cancer diagnosis. And so I told this story to Sharon and to Amy, and they said, great, you're the expert, come give a talk. Well, the question was, where's our gift box? Where's our goodie box? I didn't know how many people were going to be here today, but there's not enough lube in all the Walmarts for all the folks who really need to be here having this conversation today. So we do have some free gifts for you, and this is probably the only talk I've ever given where there's a box of vibrators at the door. And yeah, so there's something you don't hear every day. But this is why we're here, right? Everybody wants to talk about it, but nobody wants to talk about it. So we're going to get into it. In our outline today, let's see. I'm not able to see the slides other than looking sideways. Oh, I'm too short. Okay. All right. Can everybody still hear me? So we're going to be talking about how this is an underaddressed issue in survivorship. We're going to identify some ways for you guys to identify sexual dysfunction. What is it? How is it defined? And then we're going to talk about some resources here today, because I think that's really why we're here. So let's talk about screening. We all know that screening for breast cancer is it's fairly robust, fairly archaic still with mammograms. You know, one of my patients calls them the smashograms, but it's necessary. And it's an essential part of screening for something that affects 1 in 7 now. Every 14 seconds, someone is diagnosed with breast cancer. But how many women are screened, how many men with breast cancer are screened for sexual issues after breast cancer? So look at the little smaller heading, 80% of prostate cancer patients. 80%. 8 out of every 10 men get asked about sexual function when they get a diagnosis of prostate cancer. And only 29% of breast cancer survivors even report that they've received any information regarding sexual issues. It may very well be less than that. And so women with cancer, particularly breast cancer, are disproportionately screened and disproportionately treated. And, you know, it's sort of the silent elephant in the room that nobody really wants to talk about. And the National Institute of Health, they did a survey, and they estimate that about 40 to 100% of cancer survivors, particularly breast cancer survivors, have a sexual problem after therapy. So 40 to 100, which means that 60% of the people were probably lying on the surveys, right? I mean, this is a ubiquitous problem, and about 50% of women with other gynecologic cancers and or breast cancer have some serious concerns. And again, I think these are probably underreported values. There's a lot on this slide as we talk about some disruptions, but more than 250 million women diagnosed last year, more than 3.5 million survivors. Why is this not at the heading of every article and every women's magazine? Why are there not campaigns? Why are there not pharmaceutical companies with these commercials where they talk longer at the end about the side effects of the drug than they do the drug, right? We've all seen those metastatic breast cancer commercials, and they just kind of keep going and keep going and keep going. It's like buying a car. But why are we not talking about this? And so the psychosocial consequences of the diagnosis and the treatment, both of which can be temporary and then could be a little bit more long-term. You know, we're talking about losing a breast, one or both. We're talking about scars that may be uncomfortable, or scars that are painless, that still may be a very internally and psychologically painful reminder of something that happened to you that was completely out of your control. Now we're talking about alopecia. Now we've lost our hair, we've got lymphedema and swelling in places, our weight changes no matter how many Live Strong programs we go to, right? You know, we all go and you're living strong and you're gaining weight, and you know, nobody's talking about these things and how it affects your sexuality, how it affects your intimacy and your view of yourself. We've got to deal with and talk about premature menopause, and also the loss of fertility. You know, when we look at the numbers of young women who are offered counseling, premenopausal women offered fertility counseling and egg preservation, those numbers are historically very low. And we could do a little bit better as a medical community. I stand here, for better or for worse, on behalf of the medical community saying we could do better. And it's not just at the end. And so as surgeons, we like to fix things. This is why we went into surgery. There's a problem, we want to cut it out. There you go, that's our banner. But our sexuality, our sexual function, our intimacy is impacted at every point along the treatment continuum. So whether we're talking about surgery, what happens during radiation if you have early stage breast cancer and you don't need chemotherapy, and then what happens in the adjuvant stage, which could be anywhere from 5 to 7 to now maybe 10 years, and the impact that they all have on patients. And so I think these are timely things for us to talk about, and hopefully we'll get a chance to field some of your questions at the end. So there are some anatomical changes. Anatomical changes associated with the loss of estrogen. You could have vaginal shortening, reduced elasticity. Everyone here probably knows, the side effects of AI. You begin to have thinning of the tissues and the lining of the walls of the vagina. And so that results in something called dyspareunia, which is painful intercourse. You can have increased chance for urinary tract infections, increased yeast infections, and it really results in a vulvovaginal atrophy, VVA. Is a term that you probably want to get familiar with and get comfortable using as you have these conversations with your physicians about it. There can be damage depending upon the surgery. So this slide is taken from Basson et al., and it covers a number of female gynecologic surgeries, but issues with the clitoris, issues with stenosis. So when the vagina and when the muscles are not exercised, when they're not utilized, what do muscles do? They atrophy, they weaken. So now we have weakening and some stenosis of the vagina. We see changes in our physiology with fatigue and anxiety. Again, infertility, postcoital bleeding is a very, very common concern, and we'll talk about some ways to mitigate that today. And a negative body image. We have some feelings that we're not attractive. I have a patient of mine, she's 47 years old, and she came to see me about 4 years ago, and I was a fairly new physician in this health system doing a fairly new surgery called a nipple-sparing mastectomy. And there are not too many centers in the city and outside of the city that really specialize in these. And as a fellowship-trained breast surgeon, we take such great pride in doing surgeries now that help to reduce the stigma of breast cancer. We hide the scars. I can do an entire mastectomy through scars this big underneath the breast, keep the skin, keep the nipples, implant-based reconstruction. We've got now nipples that point due north till you're 90 years old, and hooray, right? And we're going to the meetings, and let me tell you, go to the plastic surgery meetings, pictures everywhere of beautiful, symmetric breasts and nipples that are going bing, and these women who, they're cut off, you can't see whether or not they're smiling. They're not all smiling, because only up to 25% of those women will retain sensation of those nipples that look so great. And nobody talks about that. Nobody talks about the loss of sensation along the skin and the nipples. Nobody talks about the pain from scars and from radiation. And so, we put a lot of lipstick on this pig to try to make it, make it better. But really what probably will make it the best is to start to unroof some of the wounds and really kind of get into some healing that needs to happen. So I've got this patient, she's 47 years old, and she looks fabulous. And I walk in, I'm going, oh my gosh, look, you look incredible. You've lost weight, you're exercising, how's your quality of life? And she said, oh, things are good. I said, okay, kids back in school, they're starting school soon. We went camping this summer, we did great things. And there's always this point in my exam where I sit down and I look at the patient and I say, okay, how's your intimacy? And that's the moment. If you're a person who watches ESPN, it's the moment where all the football players start to cry. If you watch Oprah and Super Soul Sunday, it's the moment where Oprah asks the question and the guest speaker does this. And they begin to cry, and everybody at home begins to cry. And so I'm looking at this patient, and she's fabulous. She's 5'9", and she's got great symmetric boobs. And she says, I keep my shirt on when we have sex. And it was such a devastating hush in the room, because it was a great reminder for me that although I feel like I've done this patient a service by preserving her skin and her nipples and some sense of confidence in her femininity, it's still been removed. And so there's so much more, I think, when we talk to our physicians, and we'll talk about how to have some of these conversations, because like I know, your doctors aren't bringing this up, right? Right. So the challenges. Well, here's a lot more data. The treatment is complex, it requires coordination. Surgeons are the least likely to address these concerns. And who do we see every 6 months? I see my cancer patients every 6 months for 5 years. How remiss, how lousy of a surgeon, how lousy of a doctor, how lousy of a woman would I be if I didn't have these conversations with patients? But we're missing the boat. And it's complicated. This is a really busy, complicated slide that talks about the different pathways that are involved in breast cancer. We've got inflammatory responses, acute and chronic inflammation. We have apoptosis and cell death. And, there are drugs and there are interruptions to this pathway that we have figured out, we have manipulated. And we're still working very diligently to figure out the rest of it, because you can see it's a really, it's a tangled web that cancer weaves, right? But at every point in the treatments that we figure out and the pathways that we target, there are challenges. So you can see, we target one pathway. Let's see, can you see that on your screen? Great, and now we've got premature ovarian failure. We've got vaginal dryness. Now we've got chronic pain, fear of recurrence. We've got painful intercourse, fatigue, recurrent UTIs. And so for everything that we do, there is an equal and opposite reaction that has a result and has an impact on patients. And this is an area that is sorely in need of research among physicians. And you guys know, like I do, the early breast cancer treatments, radiation, chemo, even the monoclonal antibodies, which, many people are very excited about because therapies are becoming more and more targeted, And so more and more targeted therapy should mean less and less toxicity, right? But what you don't know is that, even if you meet criteria for that monoclonal antibody, you still have to get a toxic drug up front to sensitize your cells to the monoclonal antibody. So these great commercials for the PD-L1 inhibitors, and it's fantastic, and they're wonderful agents, but you still need to give cytotoxic drugs. For the HER2 positive patients, for those of you who've had to have Herceptin and Perjeta, you know that there's still the cytotoxic part, and then there's the maintenance therapy. And so we've got hot flashes, depression, weight gain, cardiovascular effects of estrogen deprivation, chronic fatigue, arthralgias and joint pain, osteoporosis and bone fractures, secondary malignancies that are potentially associated with some of the treatments, tamoxifen in particular. Although endometrial cancer is not exceedingly high with tamoxifen, it's the #1 side effect that you'll look up. If you Google side effects of tamoxifen, you'll see #1, uterine cancer, #2, blood clots. Sexual dysfunction, cognitive dysfunction, and this is a really big one. The cognitive dysfunction associated with all of this, because this is a very nasty positive feedback loop. There are models that talk about, and I'm not sure how this shows up for you guys, but models that have been developed to talk about the things that we all know. So the couple's relationship with their intimacy, right here. There are some enhancing behaviors, and then there's some relationship disruptive behaviors. And so we can talk about reciprocal self-disclosure, partner responsiveness. If you don't have a partner who's responsive, guess what happens to the intimacy? If you don't have a relationship to engage in, what happens with the single patient? There was a great segment on NPR about 2 months ago where a woman who was a researcher from the University of Delaware got diagnosed with breast cancer, and she'd retired, and she said, I went and I did my research because I discovered that I had a type of breast cancer that was potentially fairly deadly, and that the treatment would be toxic, and that it could drive me for a loop. And she said, so I said in my mind that this might be what I needed. I went to this medical center, and they told me, yeah, you'll need these things, but maybe we won't look at these things, or we shouldn't put you in a clinical trial. And she said, and I went and I asked about clinical trials, and they were not offered to me. And she said, I didn't really think about why. And then I went to the next center, and she said, I saw a surgeon, and I asked about this treatment, this more aggressive therapy. And he said, oh, no, are you married? And she said, well, no, I'm not. And he said, well, we should probably do these things. Let's do surgery first. Let's do that. And she said, but what about this one? I read that this one improves my chances for survival. He said, well, no, you don't really have the support that you need. And, we should probably just go to surgery and do these things. And she said, I knew that I was being offered an inferior option because I was single. And she said it would have been better. He was paternalistic, but he didn't realize that he was doing it. And it would have been better if he had deliberately done it than by accident, because this means now that it's not on his radar. And she said, I began to tell him that, wait, I've got neighbors, I've got cousins, I've got a church, I got all this support. And he couldn't get past the fact that because I was single, I didn't have a husband, and therefore I probably did not meet his primary criteria for a clinical trial. And then the article went on, this was on NPR radio segment, she began to describe the literature that shows that women who are single have about a 30 to 40% increased risk of death from breast cancer, stage for stage. And it's multifactorial for sure. But I think not having a partner certainly can affect how we think about our intimacy and how do we uncouple intimacy from partnership, you know, in ways that you can understand and in ways that even that doctors could even relate to. And so there's a whole psychosocial element that doesn't always come out in the clinic. But all of these things, the negative, the avoidance, the criticisms, the pressure, they all impact how couples respond to each other, how partners respond to each other, which then will impact the physiology. And I think that's a real take-home message here today, because we could talk about a number of drugs, and the pendulum swings very widely regarding which drugs are FDA approved, not just for women's sexual dysfunction, but now we've got a very unique situation where we have women with breast cancer, women who perhaps estrogen is not the best option for you. And so where are the trials? Where's the data? And there's such a scarcity of it. And so as we begin to think more and more about clinical trials, it will be increasingly important for us to consider clinical trials for women who have breast cancer so that we can begin to understand how these drugs are going to impact you and find safe alternatives to estrogen and find out which types of estrogen might be safe if we have to use it. At what point is it a consideration? And so this is what we know. Cancer diagnosis, you know, it causes the guilt and shame. We've lost some control, right? This one thing that we couldn't control, and you know what happens as a result of that is we want to control everything, every single thing we can. I mean, we make elaborate menus, we go into the market, we're meal planning, we're doing all the things that we're too tired to do. We're already stressed and we're already tired and we're already a little sore and achy and irritable because we're not sleeping that well and it's hot and, you know, like this is a horrible thing. But now we're micromanaging our families' lives, right? So we're losing control, and some of us have lost some dignity. I have some of my Asian Indian patients who wear burqas and saris, and they don't undress in front of their loved ones. And so they get undressed in a closet, or they go in the bathroom and they close a door, and no one ever really sees their body, and they don't want to see it. They turn the lights out. And so there's a huge dissociation. And it's not just women who have a religious reason for covering. It's plenty of us who are maybe Protestant and Catholic and everything else, and atheists and, you know, tree huggers and everything in between, right? We dissociate from ourselves. And how does that affect our ability to see ourselves as a sexual being? And you couple that with this fear of dying, or worse, that I should be grateful to be alive, right? I can't tell you how many of my patients with early stage breast cancer come in, and I feel like I need a bumper sticker, Sue, that says #I'm blessed. And it's a sarcastic bumper sticker, because yes, you are blessed, and yes, we all are, but it's not the cure-all blanket. It's not the statement that you say when life isn't going so well and you just don't want to tell anybody about it. And so I'll say, you know, how are things going? Oh, I'm good, I'm blessed. And okay, and we'll talk about, you know, the breast exam. We'll talk about our diet and exercise, and we've gained 5 pounds. How's it going with exercise? Oh, yeah, I'm blessed, you know. And we'll just keep going, and it's a blessing to be here. And I'll get my hand on that doorknob, and I'm getting ready to walk out and say, okay, anything else? And then it begins. It's like, this is the reason for the visit. This is the reason for the exam. And we sit down and talk for another 40 minutes. But the anger, depression, and communication about, the concerns about communication with loved ones. And this is really interesting. I've got a patient who is 82 years old. She came to see me about 2.5 weeks ago. And she's a fairly stoic woman, and she's a widow. And I said, well, how are we doing today? And she said, I'm doing okay. I said, all right. And she's kind of reserved. And I give all my patients a hug. I'm a hugger. If you see me, I'll probably hug you. If you don't want to hug, just stick your hand out so I'll know, because I don't pick up on context clues. And so I give her a hug, and she's kind of a little withdrawn, and I listen to her heart and her lungs, and we do the breast exam. And, you know, I try very hard to meet people where they are and make patients laugh. And you should leave my office, even if you have a cancer diagnosis, chances are you're going to leave my office hopefully smiling or laughing or feeling somewhat partnered with, if not optimistic. Optimistic is the goal, but at least partnered with and understood and heard is truly the message. And so I finally say to her, I said, what's going on with you? I say, are you okay? Because you seem a little, I don't know, a little anxious maybe? Because she's sitting there like this, you know, kind of rocking, and she's got her fingers, and she just seems like she doesn't know what to say. And I said, we've been doing this for a couple of years now, you and I. We got a hot date every 6 months. What's going on? And she said, well, She said, you know, I have a neighbor. There's a man who lives down the street from me, and his wife died about a year ago, and she said, and he was so nice, he would come over and mow the lawn, and he'd help out around the house, and he would come break bread with me and my husband, and then my husband died, and, you know, and now we're both single, and she says, and he invited me over. I said, well, how wonderful is that? I said, nope, how do you feel about that? How does that make you feel? She said, I feel scared, and I feel anxious, and she said, but I went over, and we watched a movie. I said, all right, very good for you. High five, fist bump, this is great. And she said, yeah, and we held hands. I said, how did that feel? And she said, it felt really good. And I said, so before this, when's the last time you held hands with somebody? She said, not since my husband died. And I said, how about him? And she said, well, his wife was sick for a long time, so, you know, he maybe hasn't really cuddled with anybody. And this is the part in the conversation where we talk to patients, where I talk to you and I talk to myself as a single woman. And I say, well, who's touching you? Who rubs your shoulders? Who rubs your back? Who rubs your feet? You know? Who says really nice things about you and loving and affirming things? And so as we talk about this topic of sex, you know, somebody call out to me, what's probably the number one, and I sound like Brene Brown, I gotta tell you, I'm like, totally, the number one thing that you would associate, the number one trait, the number one quality that you have to bring to the table in order to have good sex? Confidence? Yep, that's a good one. Someone said self-confidence. Give me one more, and it's brought to you by the letter V, and it is not a vagina. Vulnerability. Give that lady a vibrator, please. There you go. I get to give out vibrators. How cool is that? We should do this in the office. So, vulnerability. And she began to say, you know, and we cuddled, and I fell asleep. And it was really nice. And I said, okay. And she said, but I don't want to go any further. I said, it's okay if you do. Have you thought about these things? She said, well, you know, we went out again. He invited me over, and we went to get something to eat. And she says, and I shouldn't be saying these things to you. I said, no. I said, listen, I've been inside your body here. We got a thing, you and I. We are connected very intimately. There isn't anything that you couldn't say to me right now. There's nothing you can say that will surprise me. And this is such a safe space for you. And she said, well, we kissed. And she's sweating at this point, and I'm thinking, this is adorable. This is exactly the magic that needs to happen. And I said, how did you feel? And she said, like I hadn't felt in a long, long time. And he said to me, and she says, I don't even know if he likes me. I think he must. I mean, he kissed me. She said, but he said he hadn't felt this way, this sort of flutters in a long, long time. And I said, well, good for you. I said, you deserve that, don't you think? And she said, no, I don't know. I'm past that age. We shouldn't be thinking about these things. I said, no, you should absolutely be thinking about these things. This is the time. Now's the time for you to think about these things, for you to get your life back. And she said, well, but what do I tell my kids? I don't know what to say, And I said, well, why do you have to tell them anything? Who's the mom here? How old are your kids? They're 50? 60? I would don't tell him a thing unless he's coming over for Thanksgiving. And even then, you can sit him at the other end of the table and you don't have to say anything to anybody. Like, let this just be for you. Just enjoy the hand holding, enjoy the movie, enjoy the cuddle. And if anything else happens, guess what? I think you're past the cutoff for grown. The meter's tipping. You are beyond grown. You are so grown, like you can do whatever you want to do. And if you want to go a little further, you can. And if you don't, it's okay. And maybe be patient with him because you're worried about you. And what if I can't? And I said, but maybe he's sitting over there worried about him. How about that? And she said, I never thought about that. I'm so glad we had this conversation. And she left laughing, she left smiling, and she said, I feel so good now because at least I know it's okay. And I'm glad that I spoke to you about this. And so, we have these patients who maybe some of you still see yourselves as sick, and some of you are still in treatment, and some of you are on the chronicity of metastatic disease that really we don't talk about with the sort of continuity that it deserves. We say words like fight, and we say words like cured, and words like remission, and it completely changes for the metastatic patient because it now becomes a chronic, lifelong journey with. You know, it's not necessarily a battle and a raging against. This is an incorporation into our life now. This is like hypertension, like diabetes, like heart disease, like everything else. And so we don't always talk about the chronicity and the ongoing part about living with breast cancer. It's always getting past it, beating it, fighting it. But living with it and being in that space and how that affects your ability to see yourself as whole is something that we should be talking about as physicians, as therapists, and as patients. It's something that we really have to strive towards. You know, we see ourselves maybe as less than a woman because we lose the very, very sexual part of ourselves. And so, you know, when I talk to patients about their surgery, I ask, how important is nipple sensation to you? And how many of your surgeons have ever asked you that? Like, how important is that to you? Because if it's important to you, then we need to try to make sure that we do surgeries where possible that help to preserve that for you. And it's not always possible. And so I had a great conversation with a 45-year-old patient of mine who came in and she says, well, I talked to my gynecologist and we got some options, and she says, you know, I'm trying at this thing again. And I said, good for you. I said, so what are we doing up here? What are your thoughts? She said, oh, I just ignore that part. And I said, well, have we ever explored what touch feels like for you? And where the sensation begins and where it ends? And what feels good for you? Because she says, well, I don't have nipples anymore, so it doesn't feel good. I said, but might it feel good to just rub here? Might it feel good to rub here, to rub other places? I said, have you ever explored those things on yourself? And she said, no. I said, so guess who else hasn't explored them? She said, you're right, my husband doesn't know what to do. He doesn't know where to touch. And many of us have this sense of betrayal, and it's a long conversation to have with a patient because, you know, I'm kind of the first stop. Once a patient needs a biopsy, and then the person who gives that diagnosis, more often than not, is a surgeon. And the number one thing that patients say is, you know, I feel like my body betrayed me. And quite often, it's your body told you something. Quite often, you know, if it's not an incidental finding, if you feel a lump, it's okay. If it's an incidental finding on imaging, it's okay. This is not a thing you could have any possible control over, and your body didn't necessarily betray you. And so you have some trouble then trusting yourself, right? You don't trust your body because you don't know what it's going to do. And you may not know how it's going to respond after treatment. And we talked a little bit about dissociation. And, you know, even for the healthcare, for our caregivers, these are super uncomfortable conversations, right? You're watching your mother go through this. You're watching your sister go through this. And they're not really dealing with their bodies. They don't want to talk about it. You just keep moving. #blessed. The grief. I think grief is something that we probably cannot understate, you know, because there's a loss of fertility for some, loss of body parts. Your life as you knew it, and I hate that saying the new normal, but, you know, in some ways it is, but it's along the continuum of your life. This is the phase of life that you're in. And so, you know, it doesn't just sort of, there's no hard stops in life. It doesn't, like, the book doesn't close and you open up a new chapter. It's a sort of an integration, and how well you're able to seamlessly integrate the events of your life, whether they're health events, whether they're psychological, whether it's grief, whether it's transitions in job, moving, marriage. You know, how we weave that pattern and that tapestry together is how a life is lived. And so there's these changes that we now have to sort of manage. And then changes in sexuality. And so, and grief comes back again and again. And this is the other thing that you need to consider, is that I don't care how far out from your diagnosis you are, if you have not grieved, it's okay. Even if it was 20 years ago, you know, you can #unblessed me, and you are, but, you know, if you haven't sat down and had a good cry about the things that you never thought would happen, or the thing that you maybe feel like you lost, it's okay to feel that loss. And it's a normal part of this process to feel it again and to feel it again in a cyclic fashion. And so it's important to acknowledge that, because we get to the point where, oh, you're 10 years, you're 20 years, you should feel nothing but elated and show up in pink everywhere you go, right? Pink flags and ribbons and sneakers and capes. And no, this thing happened. And it's okay to grieve about it. So how the partner feels. I have a young couple who, one of the patients is 44, and she rules the roost. She is the person who runs this house. She runs this husband. She's got a tight ship. The kids are you know, and she brings her husband to the appointment, and he sits, you know, in the corner. He holds the handbag. That's his, I see you guys. That's his job. He's sitting in the corner with the purse, right? And he doesn't really say a word. And we talk, and I try to, introduce him into the conversation and say, okay, so, how are things going? Oh, things are good. Did you have a good summer? Yeah, things are fine. You guys get exercising and getting out. You taking any date nights? Oh, and she's answering for everybody. And finally she says, listen, I just got to go run to the bathroom. Can I go to the bathroom? I said, yeah, go to the bathroom. And as soon as she leaves, he says, thank God she's gone. Because can I tell you that I don't know what to do? I don't know. I feel like if I hit on her, I'm worried I'm objectifying her. And if I don't touch her, then she thinks I don't want her. And if I do touch her and it hurts, then I've hurt her. He says, I don't know which end is up. And where are the support groups for men, right? Where are the groups where men sit around and, have a beer and talk about, and what about our same-sex couples? Who's talking about that, right? It's really, really tricky. And it's not something that we should overlook. It's not the thing that you don't ask about on the intake form. When you look at partnered, not partnered, married, your sexual orientation, your gender identity, all of those things matter. And so how your partner feels, well, if you're stuck in your head because you don't have nipples anymore and you're worried about, your vagina being dry, what do you think your partner's thinking over there? So everybody's stuck inside their bubbles, right? Now we're supposed to come together and boom, the magic's gonna happen tonight, right? You're headed for collision. They're confused about how to reinitiate it. The partner may feel guilty for wanting it. Your libido is low. And I'm saying all these things, not because you don't know them, but because somebody has to say it. And somebody has to speak it and give it a voice. And that's really what this talk is about. It's about validating all of those things for you. And so we're going to get to the solution part of it. We've talked about scarring and fatigue. What about numbness? What about when you don't feel your fingers, or you don't feel the areas where surgery has been? What about the shortness of breath? You used to be able to, go hiking, and now you can barely get up the stairs. Right, so how are you supposed to make it through a night of whatever? And then the weakness, the hypersensitivity. So, one of the things they may not tell you about radiation is that radiation can create this hypersensitivity because the nerves have been zapped a little, right? So every now and then you get the zing, and it's like this weird sort of zinger that reminds you, oh yeah, I had cancer. Right. And what about those sources, those pains, and the skin that feels kind of funny and it doesn't quite feel like you anymore, What about drains? Because many of us have had them. And just the decreased responsiveness. How does a man know, or how does a partner know that the stimulation is good if there's no tissue that becomes erectile, right? So if the nipples are gone, how does he know? How does she know? The effects of chemotherapy. So certainly changes in fertility, changes in dryness, there's pain with intercourse, and let's be honest, there's decreased sexual desire during chemotherapy. You are not feeling your finest, right? So you may not want to have sex. And how do you communicate that in a way that says, I'm not shutting you down or shutting you out? And how does a partner receive that in a way that doesn't internalize that as a rejection? We've got nausea, diarrhea, fatigue, nerve damage. All of these are things. And then we talked about the radiation effects. This slide, everybody's living it. For those of you who are on hormonal suppression therapy, AIs, tamoxifen, by blocking that estrogen pathway, it results in all of these things. So intimacy is more than intercourse, and the thing that probably the women in this room know more than anything is that, I'm going to go ahead 2 slides, it's this. The most important sex organ is the brain. And there isn't a lube, and there isn't a pill, and there isn't a magic bullet, and there's not a vibrator strong enough, right, to massage this enough to get to the point where you're able to achieve an orgasm, if the orgasm is the goal, and we should talk about that too. But let's go back. So here we are, talking about treating, one more slide, there. Treating sexual dysfunction. And so it's important for you as now an advocate, you as a family member, to make sure that when your loved one, if your loved one is diagnosed, if your friend, if you're helping somebody through this journey, that these are questions you might ask your doctor. And make sure you put that on the list of things I wish I knew, things I wish someone had talked to me about, because now you can sort of help somebody initiate that conversation. The changes in your body image, ovarian failure, hormonal effects. We have to validate your concerns, and that's why we're sort of taking this much time to talk about these things. We need to clarify the misconceptions. We need to help patients establish that new normal, but also we need to screen for it. And so one of the things that we're going to start implementing at our hospital is this. It's a sheet that says, are you satisfied with your current sexual functioning, yes or no? If not, how long have you been dissatisfied? And I suspect this question may remain blank, and that's okay, you know, because maybe nobody wants to write it down. But then where are you having some challenges? Little or no interest? Are you having decreased sensation? Are you having problems with dryness, problems achieving an orgasm, problems with pain, other? And then would you like to talk with your doctor about this today? Right? Like this can be a super powerful tool for our patients. If we had these with all those intake forms and all those insurance forms and all that demographic stuff, if somebody just said, are you getting laid? There it is. I mean, it could be a check yes or no. Do you want to? Do you want to talk about it? Check yes, check no. So we got to talk about this brain. It is widely recognized that women's sexuality can be particularly complex after breast cancer, with sexual problems becoming the most problematic aspect of a woman's life and also the most understated, unspoken aspect of a woman's life. I would like for you at this point to repeat after me. Pleasure is not optional. That was really, really sad. Pleasure is not an option. Pleasure is a right. It's not optional. But we've been trained our entire lives as women that pleasure is the option. It's the thing, if you got a little time left over after your busy week and you finish taking the kids and you drop mom off and you get to the doctors and you check the homework and whatever the things are, that pleasure is an option that you may get to exercise every so often. And I'm here to tell you today that pleasure is not optional. It's not an option. It's a right. You are entitled hereby. From now on, you can say, Dr. Gary told me pleasure is my right. And so the most significant predictor of sexual health after cancer is your emotional well-being. It's the thing I can't sew into you or cut out of you, although I do. That sense of well-being is something that you got to put back in. And we can help with that, but it's a journey that you really have to unroof and take some time with. The presence or absence of vaginal dryness is number 2, and then the quality of the partnered relationship. So here we get back to partners and no partners, and what are our single patients doing? And who's talking with them about that? Because we live in a society where, although there's been I think a recent survey that said 75% of women agree that self-pleasuring is something that we all do and should all do, how many of us have been told maybe not to and have a sense of shame about self-pleasure and from our childhood even. And this is a thing, like we don't think that we have the right. We don't think that we should exercise this option because we think that pleasure is an option when it is not. It's a priority. And it's a personal right. It's a personal prerogative. And there's this conspiracy of silence, and I love this because it really is a vicious circle that talks about, the healthcare professionals wait for the patient to bring it up. And if you're in a busy center, you might have 10 minutes maybe with the actual person who is caring for you. You might get a resident, you might get a student, you could get a fellow, you may get a nurse, but the surgeon or the medical oncologist, the time is limited. And you may not get to see that person at all, depending on where you are in your survivorship journey. And so they're waiting for you to bring it up. You kind of want to talk about it. You're waiting for the doctor to bring it up, and the healthcare professional doesn't want to bring it up because guess what? We're not experts in sex. Nobody brings a box of vibrators and lube to our offices and says, here's how you have a conversation with patients about sex. There are no classes in medical school yet that cover this sort of topic. But there should be, because how many people, 40 to 100% of women with breast cancer, are having the same issue? And you carry the burden, and you have this missing sense of entitlement. You don't see yourselves as someone who should care, like my 82-year-old patient. No, I should be past that now. No, you shouldn't. And so you have to make sure that you sort of reclaim that for yourself. Or this one, I can't ask my doctor that. If your doctor looks like Doogie Howser, you might not want to ask your doctor about that. We get it. But your doctor should be asking you about it. And you should have the intimacy with your healthcare provider, with your navigator, with your nurse, with your practitioner, with your PA, with your NP that says, hey, listen, I got a thing. This one's, it's a little sensitive. But can we talk about this? And that person has to now sit down and be able to have that conversation with you or be candid enough to say, you know what, I don't have all the answers here, but let me get you some resources. And so we have to do better. 68% of people want information on the changes, preferably in a written format. So now we got to write something down that says, here's a prescription for intimacy. Take this home and take 2 of these vibrators and call me in the morning. No, don't call me in the morning. The ratings for satisfaction are the highest with the breast care nurses and the lowest for the oncologists. Big surprise, right? Because we've completely uncoupled the changes to your body from the treatment we're putting in your body. Those 2 things are totally separate. There's a whole separate part of the building and a part of medicine that's designed to talk about side effects versus treatment. And the integration of those things is the conversation that needs to happen. And so the recommendation from this article in the Journal of Advanced Nursing 2013 says that all members of the team need to take responsibility for informing people about how their treatments are going to directly affect and impact your sexual function. And these should be a routine part of oncologic care. If it's the last thing I do, I'm going to see this implemented at least in the surgeons and the fellows that we're training who take care of breast cancer. And here's the reasons why we don't. We're afraid. We're afraid of saying the wrong thing. We're uncomfortable in our own sexual lives. Maybe we're not getting any either. We have relationship difficulties that predate breast cancer, and we have sexual difficulties that are completely unrelated. And here's the communication errors. The receiver assumes that they assume what the speaker is saying, and they're trying to be a mind reader. And this happens in our relationships as we begin to broach these conversations. And this is why these conversations stop, because you assume that the speaker's a mind reader rather than getting clarification. Or somebody blames somebody. Or somebody tries to fix it and offer advice, right? Because that's what partners try to do. They want to fix this problem. Or they kind of keep it general and they don't really get to the heart of what the issue is. Or they find that sex is a difficult topic, And there's got to be a better way to talk about this. And so it's a renegotiation or a negotiation, because maybe you've never had these conversations with your partner. Where there are some rules to how we're going to talk about this, and agree to talk about your feelings. Don't talk about mine, don't talk about your neighbor, what are you feeling right now? And agree not to place blame, agree to listen to understand, and then maybe mirror that back. So what I hear you saying is this thing. But probably more important on this list, develop goals as an individual. What are your goals in intimacy? And if you have not sat down with yourself and had a candid conversation about that, how do I bring this back into my life? Like, I'm living, but I'm not living as fully as I would like to. And sit down and strategize about that. When do we do that? And what are some of the things that we can do to address this? So for the vulvovaginal atrophy, there are some over-the-counter regimens. Over-the-counter, I recommend for my patients Replens. Replens is a vaginal moisturizer. Just like we moisturize and we exfoliate our faces, we moisturize our skin, we should moisturize our vagina. So it's a vaginal suppository that is not estrogen-based. It is every 3 or so days, so 2 to 3 times a week. If you're on an AI, you may want to consider a vaginal moisturizer, because this will help your tissues to remain soft and supple. It will help with some of the pain, some of the shedding, some of the bleeding. I recommend different things for lubrication. I think I've got another slide on that one. And then there are some prescription options. So Reverie is a hyaluronic acid. I know you guys see the Maybelline and the L'Oreal commercials, and it's all about hyaluronic acid in the face. Well, guess what? It works in the vagina too. And what it does is it binds to the tissues and it increases the moisture and the hydration of those tissues. And so that's a prescription basis. But there are some coupons you can ask your doctor about. And you could try it on a trial basis maybe for 3 months or so. And if you like it, then you could continue with that. But that's a prescription hyaluronic acid that is not an estrogen-based treatment. And there is another called prosterone, which is a DHEA, which is, it's called Intrarosa. So Intrarosa is a supplement that could be used, but is not yet FDA approved for the breast cancer patient. Because the question is this, and when we look at the pathways of what gets converted to estrogen, kind of all roads lead to estrogen, and estrogen makes things grow in an oversimplified fashion. So we drink too much alcohol, and alcohol gets converted to estrogen in our fat glands, and estrogen makes things grow. And this is the basis for the pills that you take that block your estrogen when you're postmenopausal. They're not shutting down your ovarian function, they're blocking the conversion of stuff into estrogen. So DHEA is a precursor to estrogen. It's a weak precursor, but it does in some people, get to the estrogen pathway. How that is, how safe it is in breast cancer. There's a couple articles that say it's safe in breast cancer, and there's a clinical trial that's accruing right now, I want to say out of MD Anderson, that we should look into for our patients, because this is something that, the DHEA to estrogen conversion may be such a small conversion factor that there's not a huge systemic absorption. Okay, and so as we begin to think about what our quality of life should be, there are, for many women, estrogen is going to be a role in that. It's going to play a role, and that's okay if quality of life is so severely impacted that it's what you need, because if you're not living, you're not living. I don't care, you're stage 1 breast cancer and you're likely to be here 5, 10, 20, 30, 40, 50 years. If you're not living, we got to do something different for you. And then some finding alternatives, so resisting the coital imperative. Who says that sex and intimacy is all about an orgasm? And it's all about penetration, right? And then including secondary activities. So secondary activities, oh, here we go, here's my slide. Silicone viscous lidocaine at 4%. Now CO2 laser therapy has been shown to have some short-term effects, but the long-term effects of CO2 laser therapy and the sort of vaginal rejuvenation it hasn't been demonstrated. Anecdotally, I have some patients who've had early successes, but it's expensive and it's fairly uncomfortable. And so it's a good conversation to have with your gynecologist and with your gyn-onc to talk about these things. Phytoestrogens and herbal supplements. So I'm a DO, I'm an osteopathic physician. I am a fan of Western and Eastern medicine meeting in the middle. There are supplements that you could consider that will help to increase your libido, including black cohosh, ashwagandha, ginseng, ginkgo, chocolate. Careful on the chocolate. But we gotta get ourselves in the mood here, We should talk about exercise and pelvic floor therapy. And if you're part of any major health system, particularly here in Philadelphia, but around the country, there are pelvic floor therapy programs where we can begin to talk about how, when I giggle, I tinkle a little. And have that conversation about the floor and about the muscles, how to strengthen those muscles. And then mechanical, so vibrators and dildos. Oh, joy. Well, dilators, yes. And so somebody said, well, dilators? There's a lovely kit here, and I don't know how many of these kits that we have, but here's a kit of 1, 2, 3, 4, 5 different dilators. And so the purpose of vaginal dilation is this. If you don't use it, if you don't stimulate yourself, when you are ready to have intercourse, you're going to be very disappointed. Your partner is going to be potentially very disappointed as well, because you haven't figured out what works, and you have not stretched and used those muscles. Remember we talked about vulvovaginal atrophy, right? So the muscles are atrophied, the tissues are weak, and they're ripping. So you have some work to do. There's some homework here. I'm sending you all out with homework. And the homework is to go figure out what you like all over again. Spend some really, really good time with yourselves. Because if you don't know what hurts and what doesn't hurt, you're not going to be able to guide your partner in that instant where nobody needs to be thinking about pain. And so the prep period needs to look like, what do I like again? What feels good to me? And so you've got to spend some time with yourself, touching yourself in all the places. Stimulate your clitoris. Does that feel good or does it not? And first, stimulate your mind, right? And develop a regimen whereby it's okay to use a dilator. Because guess what? It gets really small. And the pelvic exams are getting fewer and fewer. Now you're every 3 years, every 5 years. You may not be getting a pelvic exam every year, but even that doesn't really, it's painful and it's uncomfortable if you do not routinely use those muscles. And so I think it's really important to talk about the benefit of dilation and to get really comfortable with understanding and using it and spending that time with yourself, because this is the intimacy with yourself that will pave the way for intimacy with another. Because you haven't gone through this. What's this guy? This one's a breast massager. This breast massager here looks kind of like a wide open speculum. It's a cup. Can I open these?
Are these door prizes?
There are some available. I think that there's a box and they'll be giving these out. But here's a breast massager. Looks like a set of butterfly wings. And you put these on, and now you can begin to massage so that you can see what feels good. Where does it feel good? Maybe it feels better on the side along the scars. Maybe it feels good at the bottom, at the top, where the sensation sort of stops, right there at the top on those skin flaps after mastectomy. And so here's some time that you can spend with yourself, getting to know yourself again. Because in the time when you want to be intimate, you do not want to be saying, ouch, 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 wait, wait, wait. Which is, it's what happens, and it's okay. There's a couple others. There are curved massagers down here, and there's some other pulsating arousers. These are tools that we should be really, really comfortable with. And I tell my patients, you know, I give out a little bottle of coconut oil. In a little dropper bottle. I get the liquid coconut oil because it's not quite as messy as the solid. And I put it in a dropper bottle, blue or green or something cute, and put it in a little silk or satin sachet and say, here, put this in your pleasure chest. And they say, my what? I said, you don't have one of those? No. Well, go to Amazon or somewhere and get yourself a wooden box that's really pretty, and like, you can decorate it, you can make one in your craft class. Give yourself a box and start putting stuff in the box that's going to make you feel good, so that when you're ready to, you know, to stimulate, or you're ready to have intimacy, you're not reaching in for a jar of something and, you know, trying to make it sexy. Now we got something that smells good. This one's coconut. This one feels good. You know what they all are. You have carefully prepared yourself a little treasure chest, a pleasure chest of things that you know that works for you. And that is really, that's probably one of the most important things that I could say to you today, is that you have got to spend the time stimulating yourself, whether it's watching something and getting visual stimulation, whether it's touching yourself, whether it's writing and journaling, whether it's, you know, all of the things that lead to sexual comfort, because these are not things you ever really explored in your life, right? Nobody told you when you were starting out having sex that these are things that you needed. You needed to be well rested and hydrated. Probably need to exercise a little bit and feel good about your body, have good self-esteem. You probably had some of that stuff, and some of us never had it. And now we're like, yeah, love your body, breast cancer, love yourself. Doesn't always happen. And so there has to be a very deliberate effort to love yourself. So hydration, rest, multimodal pain management. If you are having pain, you're not going to have good intimacy necessarily, unless you have done some things or wrapped your mind around that pain. So figuring out where your pain is, and then coming up with some things to try to manage that pain. So if your pain is incisional, if it's at scars, well, then there may be some massage that needs to happen. Maybe we need to get you some arnica cream. Maybe you need a little viscous lidocaine down there, you know, if it's vaginal soreness and dryness. There are things that we can do to address your pain. Maybe it's acupuncture and acupressure. So, you know, these are great tools and things that you should consider in preparation for intimacy, because it's intimacy with yourself. And so this intimacy with yourself precedes the intimacy with your partner. Yoga, physical therapy, and then incorporate your partner. You got some great tools here. If you're candid enough to have those conversations and to be vulnerable enough, how wonderful would it be to say, no, put this over here, it feels better. Or say, you know what, could you move it down a little bit? Because now this is a shared experience where someone else gets to see what pleases you and take a role and have a part in actually pleasing you outside of the expectation of sex and orgasm. Because at the moment when we decide to have intercourse, we have our date night. We haven't had a date night in 6 months. We're having date night. Guess what? All that pressure, it's right here. And so the other thing that we have to do is we have to really, really have great communication, because everybody's on a separate journey. And I'll tell you this story, and I'm going to get ready to wrap it up pretty soon. But one of my patients came to see me, and she's rocking and rolling. Early stage breast cancer. I said, how you doing? Great. How you feeling on the AI? Any side effects? You know, joint aches, vaginal dryness? No, no, no. I said, well, how's your intimacy? You getting laid? And she said, and she began to cry. I said, well, I asked you about, is it the pill? And she said, no. She said, it's my husband. And she said, and Dr. Gary, you know, we're 3-time-a-weekers, and something happened, and I don't know what it is. And I said, well, you know, has he had this problem in the past? And I'm thinking, great, you know, this is where I live, right here. This is the surgery I do. This is this, and she says, well, no, he hasn't had it. You know, he hasn't had this problem before. I said, any new medications? She said, now that you mention it, he did go see his cardiologist about 3 weeks ago. And I said, and did they put him on a new blood pressure pill? And she said, actually, yeah. And I said, well, what's the name of it? She said, oh, I don't know. It ends in olol or something alol. I said, a beta blocker, like labetalol or, you know, metoprolol. That's the one, the Metro one. I said, well, I would like for you to go back and tell your husband that you were in the waiting room in Dr. Gary's office and you overheard these two women talking about how their husbands got put on a blood pressure medicine called metoprolol, and how as a result of this, their husbands were having some challenges. And the other lady said, well, my husband talked to his cardiologist. And I said, I want you to make up this whole scenario about how you were just overhearing these women talking. Don't say, Dr. Gary told me in order to get our sex lives back, you need to stop your blood pressure medicine and go see your cardiologist. I said, just tell him you overheard it. And she said, oh, okay, I guess I'll give it a shot, but I don't really know what to do. I said, well, he could see a urologist. He could, there are some things that he can do. I said, but let's circle back with me. I'm going to see you again in about 6 months. Let me know how this is going for you, and be patient with him, because how embarrassing is it for a man with ED, right? And this is the thing that they don't talk about either. They just gotta go and go in their man cave, and they don't talk about these things. And women are not necessarily wanting to initiate these conversations either, and they don't really want us to. I said, but just tell me you overheard it and let me know how it goes. She comes back in 6 months and she gives me this giant hug. She said, oh, Dr. Gary, you saved my marriage. I said, well, what did I do? And she said, remember when you asked me about that pill my husband was on? I said, oh, you're kidding. She said, well, it was the pill. And she said, and he switched pills and our lives have never been better. And so you think about, as this is affecting you, how might your partner be affected by other normal physiologic processes that have absolutely nothing to do with cancer? Getting older, going through menopause. You lose your libido anyway for many, many women. Some women don't. It increases to some degree. But that vaginal dryness is a real factor. And so there are some normal physiologic things that happen that are totally separate from cancer, and your partner's on a separate journey. Even for our female partners, there's a totally separate journey that's happening to a woman's body as she's going through menopause, So do consider that all sexual dysfunction is not related to cancer. Your primary care doctor can check your vitamin levels, your endocrine panels, thyroid, etc. Because when your thyroid is overactive, underactive, guess what happens to libido? Exactly. And that may not be related to cancer at all. And so all roads don't lead there, but the road back to intimacy really has to do with releasing guilt. It's the number one thing you got to get over. Because why? Pleasure is not optional. Pleasure is not optional, and you got to say goodbye to shame. And we're asking you to love a body that you maybe didn't love before this diagnosis. And so spending that time knowing yourself, spending the time in self-stimulation and figuring out what you like is going to be the key to having a better conversation and setting small, achievable goals. So just like my 82-year-old lady, maybe your goal is to just hold hands. Maybe just sit in a car and make out. Like, that's a pretty good place to start, and just make out without feeling pain, guilt, or shame. If you can kiss for 10 minutes without that, kudos to you. And then maybe we move on, and maybe we move from there. And so setting goals that are super achievable helps to build your confidence. Because if you have a bad experience, you're not going to want to do it again. You're like, oh, well, that's done. And you can't take the easy way out with this. There is no way through this but through it. You got to go through this journey, each and every one of us, for ourselves. And so setting some really reasonable and small goals are going to help you to build that confidence. It helps to build the level of intimacy with your partner, where you just say, you know what, honey, just tonight, we're going to kiss, we're going to neck, we're just going to kind of be close. And we're just going to see if we can even get aroused. How about start there? Not even go all the way. It's like being, early 20s again. I'm not going to say teenagers because they shouldn't be doing stuff, but, being in your early 20s all over again, right? Let's just see if we can even get there. Just to get excited about it and not hurt and not feel shame, not cover something up. Start there. And if you can become aroused, then guess what? Maybe we can go a little further. And maybe the goal is not an orgasm. And discussing what those goals are at every step of the way is going to be the road back to intimacy for you. So I'm sorry that I don't have any great magic. There isn't a massager big enough or strong enough to massage your confidence. So hopefully I've been a bit of a vibrator here and a massager for your confidence, for your self-esteem. Oh, here we are at the end. And I'm happy to take questions that you have.
Thank you so much, Dr. Gary. So questions have been coming in through text, so I know we just have about 8 minutes.
Okay.
Okay. So we'll take a couple of those questions. So someone has tried talking to their doctor about their concerns, but it was a very uncomfortable conversation. Is there anyone else on the healthcare team that can really help, or how do you then go about doing that?
So the question was, how do you go about initiating or reinitiating a conversation with your healthcare provider if it's been uncomfortable in the past? One, or two, is there anybody else on the team that you could talk to? And the answers are yes and yes. One, sometimes we have to train our doctors on how to treat us, right? You got to help your clinician out and say, you know, last time we talked about sex, it was really awkward. Can we talk about this again? And it creates an intimacy in that relationship that may be necessary for you to feel good about going back to that office. And it lets your clinician know there's a vacuum and a need to fill. There are navigators and nurses who are able to help. Like my nurse Suzanne Rush is here today. Thank you again for coming, Sue. But she can point my patient in the direction of, number one, a therapist, either for couples or for singles. She can make resources available to the social worker who can spend time in counseling or find resources online for patients. There are nurse practitioners. There are other members of the healthcare team, particularly if you feel that gender is an issue. If your doctor is a male and you're having a tough time and you want to talk to a woman, it's okay to say, hey, listen, is Nurse Sally around? You know, is that nurse practitioner, or is there anyone else that I can talk to that could give me some advice here? And then there are support groups. So in your cities, in your churches, in your hospitals, in your cancer programs, there should be a support group like ours. We have our survivorship circle where the women get together every month, and you know, we start a conversation, and it usually translates into dinner, and sometimes into exercise, sometimes into drinks, and sometimes into, you know, these relationships where we can begin to counsel and advise ourselves. So yes, there should be someone else. If you're not comfortable having that conversation with your doctor, you gotta think about that. And I would challenge your doctor about that and about that relationship, because we can aspire to greater, and we can grow together, and we can learn together, and it's okay. Make your doctor feel uncomfortable. He or she will get over it.
Thank you. Does diet or drinking water impact vaginal dryness?
So yes and yes. Diet certainly impacts how you feel. You know, I tell my patients the two best things that you can do to live a better life after breast cancer: eat good food and get good rest. And in eating good food, I mean drinking water. So hydration is extremely important for the body. It does affect vaginal dryness, because if all the tissues are dry, the vagina is extra dry. It's the desert. And so yes, hydration is appropriate and important. Oh boy, I just said that, didn't I? It's the desert. But we can moisturize the desert, and things can grow in the desert. They can. And so having a moisture regimen also, a water-based moisture regimen, makes, it helps lubrication that much better, because there's a difference between moisture and lubrication. Moisture is wet, lubrication is smooth. If you're using a lubricant for moisture, it's not necessarily going to work. Okay, at least not for any long-term period. And so I advise patients to do a weekly moisture regimen, and then to add lubrication when you're ready for intimacy.
There we go. Are there any products, sex products, that should be avoided because of breast cancer?
So estrogen patches, oral estrogen supplements, and bioidenticals, they are still not really FDA approved. Bioidenticals are not for breast cancer patients, but the levels of estrogen in most of those things are such that they are not recommended by the oncology world for breast cancer patients, and I'm sorry to say. However, estrogen creams, topical, 0.25% estrogen cream is something that some of my patients have had success with as a last resort. And so I think that we all agree that if all else has failed, and a topical vaginal estrogen is all that remains, then that's something that you may want to consider, particularly if you're postmenopausal, if you're younger and you have had oophorectomies, or you are in medically induced menopause. Those are things that you can certainly consider. But in general, you want to avoid things with estrogen.
Thank you. I think at this point we're going to wrap it up. I think it's probably a good place to end. I love what you said, really, about it's sort of like doing your own work first as well on yourself. So please thank Dr. Gary for joining us.
Thank you for having me. I'll be in the back. I'm happy to take some additional questions after the session.
And one quick thing just about evaluations. We do have evaluations that you'll receive. We really encourage you to fill those out. We listen to what you say. And once again, thank you so much, Dr. Gary, for joining us.